Hello and welcome to our second webinar in the Cancer COVID-19 Recovery Series, where we're going to be talking about how you can use the core model to achieve the faster diagnosis standard target and account for new ways of working in the current environment. Presenting today is myself, Ash Mahanti, and I'm also accompanied by Keith Kunper, and we're both in the National Demand and Capacity team at NHS England and NHS Improvement. A little bit about the series and what we've covered so far and what we're going to be covering later on. So we started this short series of webinars last week where we kicked off with a session on how to start your demand and capacity journey. Today we're going to be focusing on the core model and how that can be used to support service planning to achieve the fast diagnosis standard target and account for different ways of working in the current environment. Next week, we're going to be doing a session on that's focused on a model for diagnostics, including radiology and endoscopy, and focusing on waiting list sizes and best practice cancer pathways. So looking at it from a practical perspective. And in the final week, we're going to be running a session on rapid modeling of endoscopy services to support service recovery. A little bit about what we're going to be covering today. We're going to be touching on the 28-day faster diagnosis standard. We're going to be talking about how services are delivered and how this has changed in the current environment and how we can finally use the core model to support service planning and accounting for all these factors. So let's talk about the faster diagnosis standard and cancer pathways. So the faster diagnosis standard refers to the standard where a diagnosis of cancer or the all clear needs to be given within 28 days of receiving an urgent referral. Below, I've highlighted and outlined what a pathway for a cancer service for a particular tumor site may look like. Just to highlight, this is just an example. Not every tumor site may work in this exact way. For example, you may go straight to test, so your first scene and diagnosis would in effect be one step, but this is outlining what a journey would look like. So day zero, where the clock starts, is where the referral received. The 2-week wait standard is when the patient is first seen. Um, we're aspiring to get a diagnosis, so either confirming or ruling out cancer by day 28. And the first definitive treatment for a curative intent, so that would be your 62-day wait. So that's at the right-hand side over here. Again, just to highlight that the clock start for each of these pathways, the 2-week wait, 28-day, and the 62-day wait, all are the same on day zero. Today, we're going to be focusing on this component of the pathway, so from day 0 to day 28. Now, let's talk a little bit more about the core model and how this can actually support service planning in order to achieve the standard. A little bit about what the core model does. It allows you to enter the demand profile and the capacity for your service. And this then highlights potential gaps which may exist within the available capacity and the required capacity. It also allows you to calculate the sustainable waiting list size that's compatible with treatment for a given time frame. And we're going to be talking about how we configure this in the model later. In essence, what that refers to, if you need to see your patients by a particular day, what is your sustainable waiting list size that will help you achieve that? Once you've actually populated the core model and analyzed the output, um, this will answer two questions. First of all, what's going to happen to my waiting list? And we briefly talked about that. And secondly, will my patients be seen on time? So as far as demand and capacity modeling goes, these are the two questions that we want to answer. Do I have enough capacity to see my patients? Do I have enough capacity to be able to see my patients in a timely fashion? And we'll be going through that. Now, demand and capacity is just one small cog in a larger machine, and you need to think about other components. And pathway mapping goes hand in hand with demand and capacity planning. So I would like to briefly talk about some of the questions which may prompt some thinking in order to help facilitate the demand and capacity process. So, if we're talking in terms of referrals or at the front of the pathway, what proportion of referrals which you receive are rejected for being clinically inappropriate? Conversely, what proportion of referrals received then go on to move down the pathway? Out of these accepted referrals, what proportion go straight to test if that is applicable for a particular tumour site? What proportion comes back with a diagnosis of cancer, which would then require further interventions downstream of that service? What happens next? Each step in the pathway needs to be mapped to determine how your service behaves by tumour site. And again, it's really important to ensure that you are having those conversations between services and you're actually collaborating. For example, when we talk about referral received, if you then pass on that information to diagnostics, whether that's radiology or histopathology, depending on the tumor site, just to give them an indication of what to expect. This is just really important that everyone's actually on the same page, singing from the same hymn sheet, just to ensure that the focus is just not on the referrals that have received in their outpatient setting, but also further down the line. So diagnosis, but as well as treatment. So it just helps having that conversation and to ensure that you go about pathway mapping, looking at each component of the pathway, and everyone is on board with all of that. I'd like to mention a couple of resources for pathway mapping. So we've got Fundamentals of Process and Pathway Mapping, which is a session which we delivered jointly between QSA and the Demand and Capacity team. There's also the Elective Care Pathway Analyzer. NHS England has published rapid cancer diagnostic and assessment pathways, which actually allow you to achieve the 28-day standard for four tumour sites, which are colorectal, upper GI, lung, and prostate. This just basically goes through timed milestones and when you actually need to ensure these happen by in order to achieve that 28-day standard. And I'd also like to highlight a presentation done by some colleagues from the West Midlands. So this was a journey for radiology service, and they actually talked about KPIs for their radiology department by pathway. And over here, what they actually ended up doing was setting some internal milestones that any requests for a scan which arose from a 2-week wait referral were actually scanned and reported within 5 days. So we'll talk about this a little bit later on in the sense that it's important to actually understand the pathway, but also look at the service as a whole and how different types of scans or diagnostics, if you're talking about a diagnosis like histopathology or anything else in the lab, how that all plays into part. It's important to sort of model the service as a whole, but acknowledge that different types of pathways may require different aspirations in terms of time frames. Now, I mentioned that the clock start for the 2-week wait pathway, the 28 day faster diagnosis standard, as well as the 62-day wait standard are the same. And if you have referrals which go into an outpatient department first and then diagnostics and so on and so forth, it's important to acknowledge that the waiting time standards that we talked about, they're a backstop, not an aspiration. So if you can see your 2-week wait patients earlier, so rather than aspiring to see them on day 14, if you try to actually see them at day 10 or day 7 or even earlier, the time saved, those 7 days potentially gained if you're seeing them on day 7 actually translates further down the pathway, which actually then, first of all, it ensures better outcomes for patients, but it also actually gives you a bit more headroom to actually achieve those milestones that we talked about. So without further ado, I would like to hand over to Keith. He's going to talk about factors that affect demand and capacity and how in the current climate and how we can actually account for those using the core model.
Thanks very much, Ash. So what I'm going to do is I'm going to talk through some of the factors that might be imposed on top of the considerations you already have to put in place for reconfiguring your service to meet the faster diagnostic standard. And then we'll have a look through the model. And before we go to the model, we might just tie everything together just to see, just as a quick kind of starting point, to think about all of the different factors rolled into one, and then how we might actually model that using the core model, for example. So looking at COVID-19, obviously that has imposed additional changes to both demand and capacity of services across the NHS. And that, of course, includes oncology services as well. So what I'm going to do is just split that into demand, looking at the factors affecting demand, looking at the factors that affect capacity, and how you might need to consider some of these when you're actually carrying out your demand and capacity analysis of your service. So first of all, obviously with the imposition of restrictions in public contact, there has been as well an impact in terms of the number of patients that are actually accessing services. To perhaps a lesser extent for some of the oncology services, because obviously urgent referrals are being prioritized, but there's still an impact nonetheless. And one of the things that we need to do as a starting point is look at what your historic baselines were prior to the impact of COVID-19 on any sort of demand. So this would be looking at pre-March 2020 and using those as a baseline for what you would see in a, for example, do nothing scenario, so you might call it. And that's almost our first point of contact, because it's a reasonable assumption to make that as an ongoing level of incidence for certainly for cancer cases, we're not expecting COVID to have a significant change in the baseline impact as a starting point. Now, on top of that, what we need to consider is the existing backlog of cases, so the existing waiting list sizes, and if they're the appropriate size, but also what we would call unseen cases, so patients who haven't accessed the service that we might have expected to. So looking at this little chart, what we might expect to see is this line continuing in a straight line, and that would be our expected demand. But because we've got a depressed level of demand, the gap between that would be patients who would normally have been accessing the service. And of course, if they haven't been, it's not like they naturally, mysteriously get better. They will need to access the service at some later point, potentially with greater acuity, especially if it's time critical, like in the case of oncology. So quantifying that will be really important to thinking about how you plan your service in the next 6 months. The other things to think about is the rate of return to your normal baseline levels. Now, at this point in time, we're talking about November 2020, where we're midway through the second lockdown that's been imposed. And what this means is that we also have data from the first lockdown to look at as a sort of baseline for how services might be recovering. So that is actually another piece of information which you may have and can use to plan your service more effectively, and use that as a starting point for some of your expectations. And then finally, of course, on top of all that, there may be some impact in terms of the normal changes to your service. For example, the changes in levels of demand due to population changes and all that. So that's not necessarily directly COVID related, but it's something that you still have to take account of, which we'll be looking at when we actually look at the models. So that's factors affecting demand. And what we'll look at now is factors affecting capacity. And once again, there are some COVID-19 specific issues that we might need to look at. But before that, what you may want to look at is if you've already done a capacity analysis, productivity analysis, and all that kind of stuff, then that is, once again, your starting point. But you do need to revisit that because obviously there's been a lot of changes in the last 6-7 months. So starting point, what was available historically? If there were any transformation plans that were in train. But since the impact of COVID, what you may want to look at is the impact of potential pathway changes in practice. So especially if you're talking about virtual clinics, that may have an impact in terms of what the actual consultation time is per patient, and what your turnover rate will be in terms of your patient flow through some of your clinics. You will definitely need to look at what your upstream and downstream dependencies are, because especially, once again, with faster diagnostic standards, it's all integrated into quite a time-critical pathway. And this is where, as Ash was referring to, you want to make sure that your dependent chains further down the line, especially your diagnostic services, are well cited as to what their key milestones and timeframes available are like, so that they can plan their services accordingly. And knowing, for example, the volume of patients that can be expected to come through from the start of your pathway will be absolutely critical for your colleagues in diagnostic services to be able to plan their services so that they can effectively see patients in the right time, and so that you're meeting the 28-day FDS more capably. Finally, there's also the issue of staff availability. So at this point in time, once again, there's ongoing issues around availability of staff and welfare of staff in terms of the burnout rate which may affect your availability of staff. And on top of that, if there's any redeployments, these are all things that will need to be taken account of when you're actually looking at your capacity. And all these need to be factored in on top of any further changes that may be taking place. So we will just be about to go to the model walkthrough, but just a very quick recap then of some of the things that we discussed as factors to take account of when looking at modeling with respect to faster diagnostic standards. One is looking at the pathway overall, understanding what the timeframes are for each of those different parts, and making sure they're well communicated all the way through. And you may need to model each of those individual parts. And this is where the model will come into its own, because that will you'll be able to establish the appropriate timeframes and then calculate from there the appropriate waiting list sizes. And then the factors that we talked about, COVID and non-COVID related for both demand and capacity. So without further ado, I'm going to very quickly shift over to the model, if you'll bear with me just a moment. So what we see here is just the setup page for the COVID updated core model, and we'll see some links to this in the slide deck towards the end as well, if you need to pick this up. Now, what we've got here is a standard setup page where we can put in the specific specialty, put the units for our that we're working in, the operational units, and obviously put in percentile calculations for the upper and lower bounds to take account of the variation of demand. And for oncology services, we expect that to be slightly higher, and that gives us the additional headroom required to make sure that we're seeing our patients on time and being conservative in our approach to capacity. Now, I mentioned earlier on, we were talking about face-to-face versus virtual clinic sessions, and we may need to account for different appointment lengths. So we might need to weight patients that are going into virtual clinics slightly differently to face-to-face clinics in terms of the minutes available. And we'll see in just a second how we might be able to do that. In this particular instance, assuming that the clinical capacity is shared between virtual and face-to-face, so the same clinicians are running both, what we've done here is display them as two different modalities. So what we're saying here is that all the referrals for your service, and we're taking here a hypothetical first appointment, so first assessment as part of our 2-week wait pathway. They're all coming in to one pool of clinicians, and we're seeing them either as face-to-face or as virtual clinical sessions, and we're effectively splitting them into equal pairs. So we've got 160 patients on our waiting list in total, but we're kind of dividing them equally between face-to-face and virtual sessions, just to demonstrate what's going on. So when we look at the demand, what we can see is that we've been able to weight the different types of approaches here. So we can see that for face-to-face appointments, we're giving 40 minutes, and for virtual appointments, we're giving 30 minutes. And each of the patients that are then put in as demand are weighted according to those numbers in terms of the minutes required. For the COVID model, we've made some slight changes to the interface. So normally you can put in historic demand, and this will then project forward from there, assuming that behavior is similar to what you've put in terms of how demand behaves. What we can also do is actually cast forward. So this is just understanding that some of the teams out there may have actually been working with their own analytical teams to generate their own forecasts. And you can basically put in your own forecast directly, and we won't basically do any summary calculations on this. So, for example, if we were looking at data going out from April 2020 onwards, for example, this would then project forward. And just as a demonstration of what that looks like, if I go to the summary page, you can see this is showing a much more complex line, and this is directly related to the data as is, rather than any interpretation that we put in. So if I go back to historic data, for example, and go back to the summary, what you'll see is that it's much more simplified, and you see it's a straight line where we're actually just using the percentile of variation. So that's the difference in terms of how you enter demand. And on top of that, we mentioned some of the impact of demand adjustments for COVID in terms of lockdown. So what I've entered here is the beginning of lockdown for a service, or the impact of lockdown on a service starting from the beginning of November onwards. And what we've done is we've entered the restricted or lowered level of demand. So we've put it at 1,000 minutes, and basically we've said that lockdown will lift at the beginning of December, at which point it'll take about 8 weeks to return back to its baseline or normal level. And the implication of that is you can see there's a gap. The dotted line is what you would expect to happen historically. The solid line is the expected lowered level of demand. And the gap is where we would have some of those missing patients that I referred to earlier, which would basically represent patients who would normally have come in who haven't for whatever reason, and are there for potential patients further down the line. And we can see that quantified in this lower table here. So there's both the patients that were already extant on your waiting list, which you would have entered as part of your setup down here. And we've also got these quote missing patients, which are representative of that gap between the dotted line and the straight line. So the historic demand versus the actual. And what we can do here is we can also add how we would expect to be accommodating those patients, assuming the return to normal levels of demand. So I'm just going to put some numbers in here just for illustrative purposes. And you can see what impact that has. Basically, there's this extra lump of demand that occurs just around February time. And this would be an indication that we would need to start planning for additional demand potentially to come in. Although this is stuff that we're actually controlling ourselves. This is when we're intending to add those patients in as potentially, for example, waiting list initiatives and things like that. So moving on to the capacity page, what this allows us to do is just enter our clinics on a clinic by clinic basis, very much as before. But we've also added the ability to add additional templates as we go along. So this will allow you to scenario plan different capacity setups. And this will be quite important because it allows you to scenario plan for different scenarios. So for example, if we begin with, say, our historic capability or historic capacity, it might be a Monday, Wednesday, Friday clinic sessions. If we look at our capacity summary, we can see that that's plainly inadequate for the purposes of meeting capacity. And so what I've done is I'm just going to add a scenario whereby we add a few different clinics, and we might be able to just see what impact that has if we go back to the capacity summary. So we can see here it starts to match the required capacity line a little bit more. And if we're actually looking at, for example, our core sessions, we can also see what the impact of turning on and off specific clinics are. So for example, in this particular instance, we've not got our Tuesday or Thursday additional clinics, and we can look at what the impact of adding these in might be, which kind of raises the capacity a little bit. And if we wanted to tailor our capacity a bit more specifically, so if we're looking at, say, COVID clearance clinics, and we were talking about an additional lump in demand, for example, that we needed to account for either waiting list clearance for the backlog or for anticipated missing patients that were coming in. If I just zoom in a little bit to make a little bit clearer in terms of the text, you can see that we can either turn on or off individual weeks, or we can actually add specific capacities And this is just to understand that in some cases you may be phasing clinics in or overloading clinics, depending on what the situation is. So if we add in, say, 720 minutes, and say that we were looking at representing, say, 3 or 4 clinical sessions as part of a COVID recovery scheme, then you can see that we start to match the demand curve a little bit more closely, and we can then save that, for example, as a template, and then bring that back later as part of a discussion about possible strategies for service recovery. So moving on from there, we'll look at the parameters page, and this is where we can include some of the things that Ash was mentioning. So for patients that were not that are not being accepted because they're inappropriate referrals, for example, we can enter in expected percentage values and see the impact that has on how many clinical slots we need to include. We can also include patients who cancelled early and were discharged without needing a clinical slot altogether, or patients who DNA'd or had late notice cancellations that used up a slot and may need to be rebooked. So we can actually look at the discharge rate for said patients, and that all factors once again back into the clinical slots used. So it's worth bearing in mind all this we've been talking about, what are probably first access into the system. We've been modeling here the opening stages of a cancer pathway. You can do the same thing here for your diagnostic services and for your subsequent follow-ups, if any. And that's where it'll be really important, because this will help you actually look at the individual parts and make sure that you're managing them all appropriately, so that taken together, you maximize your chance of patients actually being seen in the right time frame. And this will become particularly relevant when we look at this page, the pathway page, because as I mentioned earlier, we're looking at the 2-week wait aspect. So naturally, we can set our milestone here. You need to be seeing your patients by day 7 of the pathway, for example, because that gives you headroom for 4 days if you need to rebook patients that DNA, for example. But if we're looking at your diagnostic aspects, so histopathology or radiology or endoscopy, there you might need to realign some of the numbers in terms of when you need to actually have your patients seen by, so that they'll realistically fit into the 28-day pathway. And this is where you'll be able to put in those numbers and start to look at how that will impact things like the maximal sustainable waiting list size. So this is kind of where you'll do, where you'll complete the work that you do as part of your initial pathway analysis to ensure that you're actually creating as robust a system as possible. So all this ties together in the summary page. And what we can see here is a combination of the required capacity, so what you need to provide to keep your waiting list stable, and the capacity that you have available, what you can actually provide. The dark green line represents your core capacity, so this would be your regularly funded capacity, your core clinics, and then the light green line that I'm following here represents the additional plus cost clinics. So in this case, I've actually entered those as what I call additional COVID clinics. And from this page, you can actually select different scenarios. So I'm going to go back to the basic scenario, for example, which would tell you a completely different story, where basically you don't have enough capacity. And under this scenario, you would expect your waiting list to be going up fairly consistently, which would obviously be bad. Whereas if we go back to COVID recovery, we're seeing things match a bit more closely, and this could be the basis of discussions with your service management about how you might be able to manage changes to enable some of these things to happen. If we go down, we can also see the waiting list position, which gives us the sustainable waiting list position, the number of minutes in this particular instance that you would expect to have that would be consistent with delivery of your service within the time frame, so 7 days in this instance, and what your actual position is. So here, what we're seeing is a service that's obviously got too large a waiting list, and you'd expect at some point the symptoms of this would be patients waiting too long, and the appropriate action would be to find some way to reduce the number of patients on the waiting list, and that would tie in to looking at how you would actually clear that using available capacity. Now, if you take this into context with in the context of the faster diagnosis standard, once again, the kind of actions you take that would take place at the beginning of your pathway chain, as we're seeing here, would need to be communicated to the latter ends, to the diagnostic services, to ensure that they are cited that to expect an inflow of additional patients so that they can actually manage that demand appropriately as well. So this is very much about understanding your pathway, communicating across all the different parts of the machine, so to speak, to ensure that they are prepared in advance to receive the incoming demand. Now, finally, as part of this demonstration of this model, we'll look at the planning page, which lets you look at different types of possible what-if scenarios. So here we can actually increase, for example, the demand. So I mentioned earlier on looking at not just the COVID, the impact of COVID, but also the impact of your natural population growth or your patient population growth. So, for example, we could say, what if we're expecting referrals overall to increase by 5% as part of the natural growth of demand for this particular service? And what if, for example, because of COVID, we might expect a higher non-attendance rate for appointments? So we can play with these numbers and see what the impact is and save those. So that we can actually look at the combination, the full combination back in the summary of some of these different sorts of scenarios. So you can see here, having an uplift of 5% on your basic demand with an increase in your non-attendance rates would have a negative effect in that your required capacity would start to go up above what you've already planned for. And by doing this, you can present a number of different scenarios and think about how you can actually plan your service to be as robust as possible to make sure that you can actually meet your patient needs. So that is the core model in a nutshell. And if you bear with me, I will just get back to where we were. There we go. So as a summary, and I realize I probably did a little mini summary earlier, the key thing here is you need to understand your pathways from end to end. And this is really important for faster diagnostic standards targets, because this will help you structure how you carry out your modeling. You'll need to know each of the different processes, and you'll need to be able to establish what the timing should be, what are the key milestones, and when should they take place for the different pathways. And you may be looking at quite a few different pathways. So there might be straight to test, there might be an initial assessment followed by diagnostics, there might be one-stop shops. You need to account for all of those and model, if need be, each of those separately and tie them all together. By having all those models and by being able to articulate what those timeframes are, that will help you inform your key metrics. So that would be your waiting list size, the maximum sustainable waiting list size for each of those different parts. But also on top of that, it will give you sight of what your demand and capacity balance is for each of those key areas and help you identify if there are any particular vulnerable points, like typically diagnostics, where you might need to be paying attention, because within diagnostics, there's usually quite a few different competing resources because they service the whole trust typically rather than a specific specialty. So you'd be able to actually monitor that much more closely and get a heads up if you're going to have any flow problems for patient throughput. On top of that, we need to consider the impact of COVID-19. So factors affecting demand, factors affecting capacity. How is that going to be affecting your recovery of your service in the short term? And are there any changes in practice that you might be implementing in the longer term? So would you be keeping, for example, virtual appointments and in the longer term? And if so, what's the impact on the total clinical capacity you'll be able to present forward from there? So bearing all those in mind and looking at the model, hopefully that will give you enough to get started when it comes to modeling your service and putting the information together to give you a sight on what you need to be doing. And just as a quick heads up, we do have this slide pack on our Future NHS page. And just to highlight that the resources that we mentioned, the mapping tools, as well as some of the guidance around specifics on the diagnostic standards, as well as walkthroughs of the core model, are available online. Just to highlight very quickly, the aggregation module is something that we haven't touched on in great detail, but it is a tool that allows you to look at multiple models in one place. So multiple core models or IMAS models, you can actually get a service level view of all the tools together. And if you're interested in that, then please do click on this link and look through the material that's available there. And with that, I'll hand you over to Ash just to round things up.
Thank you very much for that, Keith. So just like to thank you for your time in viewing this recording today. If you'd like to keep in touch with any developments going on in demand and capacity world, please do visit our website, which is highlighted below. If you'd like to be kept abreast of developments, so this could include updates to models, future sessions, and other resources, do sign up to our bulletin, and we'll keep you in the loop of what's going on. Also, please do join us on our Demand and Capacity Network on Futures NHS. Over there, we've got other additional resources, including the updated model that we talked through today, as long as other resources, including presentations from previous webinar series, as well as the recordings from the ones earlier in this series and the ones going forward. You can also follow our program lead, Sandra, on Twitter, and her handles over there. Hope you enjoyed this session today, and I hope that you'll be able to join us in some of our sessions in the next few weeks. Details of those were at the start of the slide and will be on the slide deck on Future NHS. So I'd like to thank you very much and have a great day.